So in this session, so I think we've spent the last couple meetings a lot of time talking about how excited we are, and we are, that we have funding now to do kind of expand the PCPCRC into our clinical trials platform, that we've received funding from the Canadian Cancer Society and Brain Canada. But that timing also coincided with the ending of our contribution from Health Canada. And so we really just wanted to take a moment at this meeting, and by moment I mean like an hour and a half, to kind of look back on and hopefully I think have a moment where we kind of just feel like really proud of ourselves, because we did a lot of work over the last 5 years and a lot of really good work, I think. And so I have the truly distinct privilege today of getting to show you a snapshot of what we were able to, again, a snapshot in an hour and a half of what we were able to accomplish over the last 5 years with the contribution from Health Canada. So a bit of a recap. So this is back in June 2021. We received just over $3 million as a contribution from the Health Canada Healthcare Policy and Strategies Program. That funding supported a whopping 13 full research projects, 13 seed funding projects. It also provided funding for our PCPCRC core staff. So if you've ever worked with Fiona, our knowledge mobilization lead, sort of management time. It also supported funding for our patient and caregiver partners and sort of the building of well, both their time, but also their support in building some of the infrastructure, that things like our portal where you can submit documents for our patient caregiver partners to review and those types of things. Also funded our meetings for 5 years. So I think it was 10, and then there was a couple extra ad hoc ones. So I think we might have had 11 or 12 meetings in total that Health Canada funded. And then also a lot of the communications and branding. So like we didn't have a website before we started this. And I think we have a pretty good one right now. And even just things like, logo design, these PowerPoints that we have here. So all of this stuff, really we had none of it 5 years ago. And so Health Canada support really allowed us to do this. Today, I'm going to focus in on sort of the first two bullets. I'm going to kind of give a recap. We have results for pretty much every project now. And so I am going to do a bit of like a rapid fire summary of all 26 of these projects that you see here. Of course, it's just going to be a quick summary of just sort of the main finding of each project. But the hope is that we can, again, just kind of reflect a little bit on what we've been able to do, how we've actually changed some stuff in care, which I think is always exciting as researchers. You have to be really, really good at delayed gratification. Serena talked this morning about how it's been 9 years of ACE Path to talk about a trial. Like you got to be really, really good at delayed gratification. So I think it's really important when we do have results to take the time and kind of look back on that. So that's the plan for today. I didn't put James first because he's my boss. This goes in order of just sort of how our proposal was structured to Health Canada. So many of you have heard of the Homer project, and this is really hot off the press. We just got our model final analyses, final for now. I'm sure we'll do some deep dives, but final analyses right now from ICES. And so Homer is a tool to help facilitate identification and assessment of unmet palliative needs. And essentially, what we found is that implementation of the Homer intervention does significantly increase the likelihood of being screened for unmet palliative needs, but also of dying in a palliative care bed substantially rather than like a non-palliative acute care bed. And it also significantly reduced both hospital harms and not just hospital, but broadly cost per day, which was pleasant. We also learned from the implementation science part of our project that local site context and workflows are actually really critical to implementation success. So often it's not just the intervention itself, but it's how you deploy it and how, compliance and how people respond to it. And we also learned that racialized and newcomer patients, even though we're flagging those individuals with Homer, the healthcare team is not responding to those flags as much for racialized and newcomer populations. But interestingly, when the healthcare team does, the racialized and newcomer or patients who belong to racialized or newcomer groups were less likely to report severe symptoms. So anyway, so we're actually working with Z to kind of dig a little bit deeper into what we're seeing there. So essentially now the next steps of this are, to scale and spread HOMR implementation nationally, because all of our pilot sites were in, pilot, I guess we had like 10 sites, but we're in Ontario. So expanding beyond that, we also are working with groups internationally in the US and in across Europe as well. And then, to, like I said, do that deep dive of how can we make sure that racialized and newcomer patients are receiving equitable care. This being recorded, is it? Yes. Okay. All right, so that's project one. How am I doing? I really only got I got to speed it up. I've only got 2 minutes per project. Okay, so Dr. Sinaraja led a project looking at improving cancer survivors' access to palliative care and actually built an EMR trigger. And so they used co-design approaches to develop and implement an advanced cancer EMR algorithm for gynecological oncology outpatients. And they actually found that implementing the algorithm and the flag did decrease the average time from cancer diagnosis to a palliative care consult, as well as to the first advanced care planning note in the chart. Also found that early palliative care referral, which they defined as within 8 weeks, increased, as well as ACP documentation increased. And in general, physicians thought this was a useful tool. So next step is really looking around expanding to other cancer groups as well as to other hospitals. And they're actually working with Cancer Care Alberta. This was done in Ontario at Lakeridge Health, but they're working with Cancer Care Alberta to expand this. And I'm going to put in a plug here for those of you who are going to ALPM. Dr. Sinaraja is actually doing a full talk on this work at ALPM. So it'd be great if you could go to that. Okay, Dr. Shu, who could not be with us here today from Briere. Several of you have probably heard of the Respect tool. So again, there's a trend. These first 3 projects are all kind of your early, how do we identify patients better? So Respect is a tool to help identify patients who are at high risk of death and unmet palliative needs in long-term care settings. And so they did an implementation study where they did work with participants, so staff and patients and caregivers in long-term care homes, and found that this is a really key goal and priority. And they felt that Respect was an acceptable tool to help sort of achieve this goal. But that staff really need training that extends beyond the early identification tool. So it's one thing to identify someone and say, hey, this is great. But particularly in the long-term care context, they were like, well, there's not really anyone here to have this conversation right now. So how do we kind of upskill and train people there? It's now been implemented in 10 long-term care homes in Ontario and 6 long-term care homes in Alberta. And so I guess next step is to kind of build that out. After several of the projects that have been done for a little while, where Fiona has had a chance to work her magic and develop some great infographics, I will put them here. Very similar to the results that I've already shared. Or so I should say my slide is actually old though, so sorry, 18 long-term care homes in Ontario, not 10. And actually have developed specific Respect training now for staff to kind of go with the intervention itself. Okay, Dr. Shu also had a project looking at physician visits for Canadians during the end of life and factors that influence primary care providers' involvement in palliative care. And they found their main finding was that 60% of adults do not receive a home visit from a physician or a nurse practitioner in the last 90 days of life, and that was true in both Ontario and Alberta. But having at least one home visit did lower the chances of hospitalization, as well as having an ED visit, and increase the likelihood of receiving medications for pain and symptom management and achieving death in the community, which I'm looking at you, Andre. I know we had a discussion yesterday. You talked about how, how can we make sure that people who want to die in the community and at home have the opportunity to do that. And anyway, this data is telling us that having at least one visit from a physician or a nurse practitioner can actually really help people achieve that. Okay. Dr. Eisenberg is in the room with us today. So if you have additional questions about the Out Loud study, I will direct you to her. But this was a mixed method study that was called the Out Loud study. And so this is what I'm going to summarize as sort of a summary of both the qualitative and the quantitative results. But essentially, people with opioid use disorder, probably unsurprisingly, face many barriers to accessing quality care near the end of life, namely complex health and social needs, stigma and discrimination in care are still is still a big issue, and broken healthcare systems, how it's described. People with opioid use disorder were less likely to receive palliative care overall, and in particular in the community, despite having earlier engagement, which reflects their complex illness trajectories. The relationship between palliative care and location of death differed by care setting and cancer status, suggesting that community death is not always the best quality indicator. And I think we've seen that actually across a lot of the studies that come out of PCPCRC, is that we want to make sure that if someone wants a community death, that we make sure that as much as possible we can facilitate that. But it's actually not everyone that wants a community death. And about 1/3 of opioid overdose decedents received early short-term palliative care in acute care settings, which actually suggests that potentially there were some missed opportunities there for earlier identification and tailored interventions. I think that's probably, there's this so this study has been published. So it's actually an infographic from ICES. So you can find more details online. But in general, sort of the take home here is that people with opioid use disorder were 16% less likely to receive palliative care at the end of their lives than people without opioid use disorder. Okay, how are we doing so far? Is everyone still with me? Okay. So this is a study that James actually mentioned earlier, led by Dr. Watt, who I don't think was able to join us today. So Christine and her team did a study looking at using tumor bank DNA to validate genetic factors that influence opioid response in patients with advanced cancer. And what they found, so we looked at a lot of charts and identified 11 genetic loci across 6 genes that were significantly associated with needing either higher or lower morphine equivalent daily dose. And so then kind of the next steps of this is to better define the role of genetics in opioid response variability. And the intent is to actually develop tools and guides for more personalized medicine. We've also talked about, when people get a cancer diagnosis, they get their tumor DNA analyzed. Can we also add in a panel for opioid response? So Dr. Colleen Weber did actually what ended up being some quite foundational work for the trials platform that we're looking to build. She did an environmental scan of palliative care data initiatives in Canada, and let me know if you're shocked, found considerable variation in palliative care data collection across Canada, both in terms of what data are collected and how that data is collected and stored. And so current measures of the quality of palliative care, importantly, do not incorporate the perspectives of patients and family members. So that was a huge gap that was identified. And so the next step is to largely fill that gap and develop a set of quality indicators that can be used to measure the quality of palliative care. And as a starting place, they're starting that work in long-term care and then can expand from there. This is a lovely infographic that was created by Fiona. I am not following our authorship policy right now. I should have a statement underneath that credits Fiona. But yeah, so it was, project was a lot of work. They did an environmental scan, also did a scoping review, an electronic survey of healthcare providers across Canada. So really a lot of work went into this. Okay. Dr. Eisenberg, who is here, collaborated with Dr. Weber to do a study of end-of-life prescribing practices in long-term care homes. And I'll go to the next slide here. Again, great infographic, Fiona. And essentially found that Across all homes, there was really high variation in end-of-life medication prescribing rates in long-term care. But in general, the homes that had the lowest prescribing rates of end-of-life medication, their residents had the highest rates of transfers to hospital, ED, or being admitted in the last 2 weeks of life. And the inverse was also true. The homes that had the highest prescribing rates of end-of-life medications had the lowest transfers to hospital. And so the next step, the follow-up from this work, is actually being led by Dr. Nick Tompkins, who has developed an end-of-life long-term care order set that is currently being implemented and piloted in some long-term care homes in the Ottawa region. Excuse me. Okay. We'll switch to virtual care. So I'm also, so the next two, I'm also going to put it in a plug. So tomorrow, the PCPCRC is actually doing the first plenary at ALPM. And there will be 3 PCPCRC projects that are really highlighted in that session. And one of them is sort of a combined presentation of this work that I'm going to share with you, and then the work that Dr. Jess Simon led as well around, in general, how we managed virtual palliative care, particularly during the pandemic and the learnings that we have from that. So if you're interested in this, there's a longer talk about this tomorrow. But essentially, the main findings were that, unsurprisingly, virtual end-of-life care increased tenfold during the pandemic. And that people with different serious illness chose, when they could choose, chose variable mixes of in-person and virtual modalities of care, which actually seemed to contribute to a decrease in pre-existing inequalities in terms of who had access or the option to use virtual care and who did not. We do suspect that substantial increases in the use of virtual end-of-life care will continue to enable patient choice in the modality of care that they want to receive, without sort of exacerbating. I think there were a lot of concerns around this idea of the digital divide and how that works. Interestingly, though, this is, again, beautiful. Thank you, Fiona. What I think is really interesting, though, is that we also had a study that incorporated some survey and qualitative work that Dr. Simon did, where in general, patients still prefer things to be in person. So we want virtual care as an option for certain things, but actually in person in general is still the preference. I think that's the perfect statement for it. Supplementary at best is what virtual visits were seen as. There was also data to show that physician home visits were associated with decreased risk of hospitalization and in-hospital death, both before and during the pandemic among a home care cohort. So that's actually consistent with findings that we saw from Dr. Shu. Part of that project was also the development of these clinician tip sheets, as well as patient and caregiver tip sheets for how to actually navigate virtual care. And all of this is available on the PCPCRC website for free. Clinician tips for sort of what to do before the virtual visit, during the visit, and after the visit to essentially make things go as smoothly as possible. And then one similar one for clients and home care clients for how to navigate virtual visits. All right. I mentioned the ALPM session tomorrow. Dr. Gagnon, who is here with us today, will also be presenting in more detail this palliative sedation work tomorrow. So I would encourage you to come and listen to that. This is a study that had a few different, there was a chart review of data from Quebec. There was also a qualitative study that was done, and then an umbrella review too. So I'm really summarizing and putting that together here. But in general, participants shared a common understanding of continuous palliative sedation, despite variations in terminology, sort of attitudes and practices. Palliative care physicians and nurses often struggled to address existential suffering or existential distress. I'll show you the next slide that shows that the existential distress was cited in about 57% of cases. But the work in Quebec also showed us that standardization in the practice of continuous palliative sedation can actually probably be achieved across these diverse clinical settings. So the next step is to look at the palliative sedation in some more real-world clinical settings. Also doing interprovincial comparisons, I think would be great. I haven't figured out yet how we'll do that because Quebec has such a good mechanism to collect data on palliative sedation that other provinces don't necessarily have in place. But also advancing research on assessment and treatment of existential distress, as we're seeing that coming up. So this is, here we go. Sort of a great slide that you'll see. I won't go through it in much detail because you'll see it tomorrow at ALPM, but you can see that psychological and existential distress was really driving a lot of palliative sedation. Okay. So severe grief during the COVID-19 pandemic. So this is a project led by Doctors Downer and Lawler from the University of Ottawa. And what this work found was that severe grief was highly prevalent during the pandemic. So we followed a cohort of 120 bereaved caregivers and found that 6 to 12 months after the death of their loved one, almost a third, I think, or was it a quarter? A third. Almost a third of patients had severe, what would be considered severe grief. Pre-pandemic times, you're looking at like 2-3% in a similar population. But interestingly, 6 months after that initial assessment, so 12 to 18 months after their loved one died, it was still almost a third of the cohort that had severe grief, and actually a quarter of the cohort got substantially worse in that time period. So there's kind of this, pandemic of grief that has happened post COVID-19 pandemic. Jump back here, but the sort of next step is that we actually right now are conducting a pilot clinical trial or feasibility and preliminary efficacy trial of looking at transcranial magnetic stimulation to treat prolonged severe grief. All right. And we're halfway here. We're halfway, believe it or not. How am I doing? I'm doing okay, I think. So this is a trial that is currently ongoing. So it's being led by Dr. Fitzgibbon at the Ottawa Hospital. This is a study looking at modafinil versus placebo to treat severe fatigue in advanced cancer. And our finding so far is that recruitment is really hard. In large part because a lot of patients are actually on benzodiazepines and other sleep aids, which we had originally had as an exclusion criteria. Because we're like, people have severe fatigue. Why would we enroll them if they're on sleep aids and a lot of benzos? And but it turns out that this is, people are fatigued all day, but then can't sleep at night. So they have sleep aids to help them sleep at night, but then they need something to kind of help them get through the day. So we're working on an amendment right now to remove that exclusion criteria. And James mentioned this earlier, but actually finding a placebo is really challenging and really expensive. It's a small pilot trial. We wanted a placebo for modafinil. And we finally landed on a company that was able to get us a placebo for, I think it was $8,000. We're doing 20 for 20 patients for a placebo, but that was the cheapest we could find. Most research organizations that were willing to provide the placebo, we were looking at quoted anywhere between $20,000 and $30,000 for 20 patients. So doing placebo-controlled stuff is hard and very expensive. So I don't know if Health Canada is listening right now, but if yes, thank you for your patience as we found an affordable placebo provider. So our immediate next steps for this is to finish recruitment, and then following up with potentially a phase 3 RCT if this is feasible to actually look at efficacy. Okay. So those were the projects that we had initially defined to Health Canada. But I think potentially one of the kind of biggest success stories, I guess, that we had over the last 5 years with the contribution from Health Canada was our seed funding projects. And so over time, we were able to fund 13 projects. So that's why I'm like halfway there, 13 more to go. We were able to fund 13 projects that really focused on supporting trainees and early career researchers in building or helping them do some foundational research that they would need to do in order to apply for larger granting opportunities. And as I go through these, I'm just going to remind people, we gave people $20,000 per project. It was not a lot of money. We're grateful for it, obviously, but as I was putting together these slides, I was really struck by how much people did with $20,000. And so anyone who was part of that program or led a seed funding project. I think it was really impressive what people were able to accomplish. So the first one, Dr. Abdalal is in a board meeting right now, but he told me he would rather be here. So he yeah. But he did a study looking at palliative care referral patterns among adolescent and young adults with life-limiting illness. And so his work found that 68% of AYA decedents had specialist palliative care involvement in the last 90 days of life, which I guess depending on what perspective you're coming from, you either think is really good or really bad. Specialist palliative care, though, was associated with lower rates of mechanical ventilation, fewer hospital deaths, fewer intensive care unit deaths, compared with no palliative care or generalist palliative care. So there does seem to be something, some magic sauce in the specialist palliative care here. And women and those from neighborhoods that had a large proportion of newcomers to Canada were actually significantly more likely to receive specialized palliative care as an AYA. So this study has actually informed a subsequent qualitative project with patients, caregivers, and healthcare providers that we actually have just completed and are working on publishing now to look at barriers and facilitators. And we're actually combining and using all this information together. We'll be having a co-design event in a few months to co-develop an AYA-specific model of palliative care delivery in Canada. Great Fiona infographic. I'll pause. There's so many of them. Okay, Dr. Gupta did a project looking at exploring facilitators and barriers to providing outpatient palliative care to refugees. And in her work, she found that refugee claimants with palliative care needs and that were insured through the interim federal health plan are actually accessing acute care services very frequently to meet their needs. And, significant barriers to having primary care services or outpatient or palliative care services, for example, included inaccessibility of provincially funded home care for refugees, as well as a lack of healthcare provider comfort and knowledge about the interim federal health plan and how to navigate that, as well as lower use of outpatient palliative care due to socioeconomic barriers. Again, a lot of times these things aren't covered. So they actually leveraged the findings from this work to create a nonprofit organization, which I think is very cool. Again, $20,000, and you're like, we created a nonprofit called GPS Health Navigators that actually connects refugees with life-limiting diagnoses to palliative care supports. Since January 2024, they have helped over 30 patients and 15 caregivers in the GTA and Hamilton region. So again, like $20,000, and like that's very directly 80 people right away that that were connected to supports who otherwise probably would not have been. There is a great video summarizing this work on our PCPCRC website. Dr. Gia, who's in the room here. And I'm having a bit of a first or full circle moment, I think, as Roberta would say, in that Dr. Gia was one of our first early career seed funding awardees and now co-leads our training and mentorship program for the PCPCRC, which we can clap to that. Yes. Which I think is awesome, and we're so grateful for. So kind of the project that started with seed funding looked at how Chinese immigrants and their families experience palliative care. And the findings here, there were sort of four main themes. First was that abandonment and alienation mark a lot of past experiences with serious illness care. And that emphasizing expertise and symptom relief may help overcome some initial ambivalence that these individuals feel towards palliative care. Palliative care really has a role to broker competing priorities within the family unit. And palliative care can also help alleviate some time-related distress by addressing illness understanding as well. And then We also have a great video for this project, so I would encourage you to head over to the website and take a look at that. Okay. Dr. Black, who, if any of you attended our last PCPCRC meeting, he actually did a screening of the documentary that he and his team developed. So this all kind of started, again, $20,000 seed funding program to looking at the bereavement experience among people who are experiencing homelessness in BC. And they found that bereavement is, in fact, a risk factor for homelessness. And that grieving in the context of homelessness is really shaped by compounding losses that people experience, as well as structural barriers and social marginalization. Many people in this work suggested that grief supports have to go beyond typical one-on-one or group therapy in general, but particularly for this population. And that community memorials, such as the White Cart Memorial, which is what the documentary is about, were seen as a very meaningful and had positive impacts on both the individual and their community. So the film that was created, it's called No Fixed Address, the White Cart Memorial, has now had 20 screenings across Canada, more than 1,100 viewers. And very soon, June 2026, it will actually be publicly available. So we're really excited for that. They have also used the results from this work to partner with the Carnegie Community Centre in the downtown east side of Vancouver, and we're actually able to secure funding for some additional grief and bereavement support for the homeless community. And they have also developed some modules for those who serve people experiencing homelessness. So they've actually had over 1,000 people now register for those educational modules and that teaching for how to better support the homeless community in grief and bereavement. All right. Dr. King, I have these reflections as they come, but we're kind of bouncing around to different spots across the country, which I'm also really happy to say it wasn't sort of all one center or one spot that was driving all of this work. So Dr. King from the University of Calgary did a study looking at improving support for substitute decision makers and actually did a journey mapping project to map decision-making needs and support tools for caregivers of people who are living with dementia. And I could read this, but actually I think the coolest thing is that they developed these really cool roadmaps. And on our website, you can look at it. And for each of these bubbles that you see here, there's actually a more detailed decision roadmap that helps caregivers understand sort of what can you anticipate in terms of the decision making that you're going to have to do. And I was going to say, and Gwen, who is one of our caregiver partners, was really involved in this work and helped co-develop these. And so if you haven't seen the full, like the details for each one, it's really, really cool stuff and really excellent. So again, all available on our website. Again, like $20,000, and people are creating these very tangible tools that are already out there helping people. Okay, Dr. Lee, who is from the Ottawa Hospital Research Institute, looked at a study exploring the experiences of spousal and child caregivers from minority groups who were caring for family members at the end of life. So this was a qualitative study. They did interviews and found that caregivers from ethnic and linguistic minority communities in particular describe substantial heterogeneity in their end-of-life caregiving experiences, and that these are shaped, yes, by culture and language, but also by family expectations and prior knowledge of the healthcare system. They routinely heard that rather than suggesting that culturally matched care in terms of care provider and patient and caregiver is required, that the base desire is actually for care providers to be mindful of, to understand and respect those cultural differences and avoid assumptions that can lead to sometimes disrespectful or dismissive conversations. Okay. Dr. Sean from Providence Healthcare did a project called Hope is Strong. And so this was a qualitative inquiry into serious illness conversations for patients who are living with structural vulnerabilities and substance use disorders. And in their work, they found that participants had unmet basic needs, and therefore their priorities during, excuse me, their priorities during a serious illness conversation were different, which I think is intuitive and makes sense. Um, Participants frequently had previous negative healthcare experiences, which resulted in them sort of guarding their feelings with healthcare providers, which could make serious illness conversations more challenging. Um, excuse me. And I'm reminded of a presentation we had, I think a few PCPCRC meetings back, um, where we had this discussion about hope and how it's really important that serious illness conversations don't take hope away, and there's a way to do it while still maintaining that. And that was really emphasized here, that hope needed to remain an important component of having serious illness conversations. Um, and they're created patient guided best practice recommendations for serious illness conversations with structurally vulnerable patients who have substance use disorders. Okay. This is a project led by Dr. McGinty, who's from the University of Ottawa Heart Institute, very heavily supported by Dr. Eisenberg, who is in the room here, and her research team. So this was a process evaluation of a palliative outpatient clinic for heart disease. So they looked at referrals from 2020 through 2023 when the clinic was up and going. I believe it still is. This was just the time frame for data collection. But 72% of referrals were assessed by the clinic. Referral sources were actually quite varied, so came from general practitioners, both community and inpatient cardiologists, as well as general internal medicine practitioners. Participants felt the clinic helped with proactive communication, provision of comfort and dignity in care and dying, prioritization of shared decision-making and patient autonomy, balancing reactivity and proactivity in care delivery, and introducing a palliative approach in cardiac care. This work has informed the ongoing design and delivery of palliative care for patients with heart failure, and learnings from this could be used to scale to non-malignant disease, to other non-malignant diseases as well. Okay. So Dr. Fink was sort of again, this is just in the order of years of seed funding over time. Dr. Fink did a project on improving end-of-life care at home by hearing the voices of bereaved caregivers and used a community participatory research approach in that work. And I would say probably the takeaway finding in this work was this idea of it takes a village, really, of multidisciplinary teams to provide caregiver support when caregivers are accompanying someone during end of life at home in the home context. Caregivers felt especially supported by seamless care coordination and transfers from hospital to home. So, which is not surprising to anyone in this room after Dr. Eisenberg's presentation before lunch. And they also found some sort of consistent best practices for support, which included consistent presence of trained care personnel, let's just say personnel, dedicated program that tends to caregiver-centered needs, provision of information about community-based palliative care services, as well as grief support. They have taken their initial findings and are now developing digital storytelling videos created by bereaved caregiver participants, and are also conducting deliberative dialogue workshops with community-based palliative care teams to design a healthcare intervention that can provide some elements of support to caregivers. Okay. Big switch. Dr. Nelson, who was not able to join us today, did a project, a scoping review rather, looking at interventions to manage conflict in healthcare, particularly in the pediatric setting. So they found 19 studies, the majority of their studies, so there's 19 of them, described educational or simulation-based interventions for conflict management, which I thought was interesting, and 2 studies that actually looked at clinical outcomes. So when we are looking at interventions for conflict management, we're not actually looking at clinical outcomes, was the finding. So although interpersonal conflict in healthcare settings is widely acknowledged as a driver of negative outcomes, not just for patients and families, but also for the care team. The evidence base of interventions to mitigate this is very limited, and assessment of any clinically meaningful outcomes is extremely rare. So they're actually currently working on developing an algorithm to identify markers of conflict in the EMR, which I thought was interesting. So that's kind of their initial next step of this work. Okay, Dr. Benares, who is from Sunnybrook Health Sciences Center, but in Ottawa, we often say he's an honorary member of the University of Ottawa Division. He did a project looking at primary language and end-of-life care in people on maintenance dialysis, and found that in decedents who had end-stage kidney disease, who were on maintenance dialysis, 40% received physician-delivered palliative care in the last 6 months of life. Median was 22 days before death. Compared to anglophones, allophones had higher odds of burdensome transition at the end of life and also a higher odds of in-hospital death. Okay. So Dr. Fan actually presented her seed funding results earlier this morning, so I won't spend a ton of time on this other than to say that I think, I think it was you, Paul, that said, we should have this everywhere in every province and, package this for us. And so I think that there are plans in place to scale the simulation program to include additional disciplines, learner groups, care environments, and also clinical scenarios, and also how to integrate this potentially into health professional education as well. Okay. Dr. Tudelmans from the University of Calgary, they will actually be presenting results at this meeting as well. So I'm going to keep this one very brief so that I don't give any spoilers. But main key with this project was there's this tool called Voicing My Choices, which is an advanced care planning tool for adolescents and young adults. And so the goal of this project was to take that tool and make it applicable and acceptable in the Canadian context. Okay, I think that was it. How am I doing? So I have until is it 2:15 that I have until? Oh my gosh. Wow. That's great. Okay. Yeah. But I'm actually glad I was trying to make sure we had at least 15, 20 minutes because I did want to, again, I've been kind of interjecting as I've been talking with, the other part of my brain has been interjecting with the other half of my brain, some sort of reflections and thoughts as they've come to me. But I would really like to take the opportunity across the room to get either questions about connections on specific projects or things like that, but also just some reflections about the last 5 years and what we've been able to do.
Thank you. Yep, we're on. Thank you again. This is wonderful to see what's happened over the past several years. I love the fact that on the website you have resources. Do you have any connections to the published papers for these? I don't see it here, but I might be missing something on the website.
Yeah, so we do have the functionality, I believe, to be able to, I'm looking at Fiona, sort of ish, yeah, maybe. What I'm going to suggest is that, so once papers are published, and I wonder if maybe we could, once papers are published, we can update the infographics with a QR code or something to the link to the paper, as sort of just so that the website's not too cluttered with resources. I think we could potentially have the ability to do it in our members only dashboard. But then can be kind of a bit of a pain in the butt to have to get to versus the public site. So maybe that would be the good link, because I should say, again, I was very worried about not just time, but you having to listen to my voice constantly for more than an hour. And And so I didn't put screenshots of all the publications, but actually most of these projects have one or multiple publications associated with them now where you can get sort of all the full details.
That'd be great. The other thing is just a bit of connecting the dots. So the EPOC project brought to mind the fact that the palliative medicine resident in Winnipeg is going to be presenting her heart failure project here at ALPM. She's got the half-hour spot. What is it? I think it's on a Friday afternoon.
Okay.
Dr. Hilary Buse, cardiologist, has been working through this. If I'm not wrong, it's 2,500 charts that they reviewed. So the results are very, very interesting. I can't tell you any of the results because she's been working on it. But I
Yeah,
think,
don't ruin her whole presentation. Yeah.
exactly. But I think that she needs to come to something like this because I think that she, she's been working a little bit of in isolation, but there's obviously a role for that and part of the palliative care across the country.
Yeah, absolutely. And I'm looking, I took it out of the slides because I was trying to keep not a minimized text, but it was, I believe there were a lot of charts in that review. I'm looking at, I know that Serena's research staff spent a lot of time going through. Oh, it was? Okay. Okay. So that would be interesting if you're saying you have over 1,000 charts. I'm like, over 2,000. So how many people, and was that a palliative care specific clinic? Okay, interesting.
I'm sorry, it was just a review of the patients, patients found within the heart failure clinic. And trying to come up with a tool to help identify those who would benefit from palliative care earlier.
Okay.
And they came up with well, she'll say it on Friday.
Okay.
So.
Okay, cool. Thank you.
I think one of the core themes, I think, of what we were hoping to do, certainly with this pocket of funding, but in general, the PCPCRC is the problem of people working in isolation is one of the common things we share across this country is that most centers have an individual person that kind of does a thing, and that a lot of centers have those people, and you can actually form quite a nice community of a small number of practitioners who can pull together and do bigger things together. And I think, it was just at lunch, I met, this interesting fellow from Halifax who's a neurologist, who's training in fellowship in palliative care. And she said she was going to come to Ottawa to do an elective. I said, oh, you're going to do an elective with our neuropal team. And she said, the what? She had never heard of the neuropalliative care team. And I thought, why on earth would a neurologist doing palliative care come to Ottawa if they weren't going to come and see this team? So, I mean, it's just so funny that, now all of a sudden there's going to be a brand new center, growing the bench, but creating the community. And I hope that as people sort of see, it's $20,000 and you can see what done with $20,000, but you haven't yet seen what they can do with $20,000 because you haven't seen where these projects have gone yet. And I'm really interested to see, I think a lot of those 13 projects will go on to much bigger things as well.
I was just thinking about tomorrow's plenary and how do we grow that community to let people know? Because I know we're only highlighting 3 themes that ALPM asked us to highlight, but will we have a slide to say 26 projects covering everything from dementia to heart failure to blah, 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 so that people in the audience can say, thank you. So people in the audience can say, I could see myself joining this. Gosh, I had no idea. And I've been working in isolation. Just we ought to use our opportunity.
Definitely agreed. And I again, right, like if you know people like this, right, don't hesitate to pull them into Fight Club. It's important.
But no fighting required. Yeah.
Question. Oh, sorry. I'll hit Serena now.
Thanks. It's so good to see all of these presented at once, having been part of this since 2018 when we first met in Toronto, and it was 2017. Sorry, and it was technically Mississauga. But it's just really beautiful to see how things have evolved. I'm struck by, the opportunity here for PCPCRC to serve as a connector across the country. And, 26 is a lot of projects to absorb in an hour, but from what I can think in my qualitative brain is already trying to sort thematically the way these things work. And I'm thinking about mapping where these are in the country and what types of healthcare providers these are with and whether it's patients or caregivers, or I think there's a lot of ways we can work to bring people together across the country doing this work. And I think certainly to Jessica's point, like part of it is bringing more people into the fold. But even among just those of us in this oddly shaped room, I think we could find more ways of collaboration, and maybe in future semi-annual meetings, we could think about just spending time like popcorning what we're all working on and just trying to find commonalities. Another thing I thought about, I know the website is, a really wonderful resource, but I wonder, and I don't want to add work to any of the staff's plate, but something like twice a year, there's a newsletter that goes out to our emails with like, hey, these are recent publications that came out from our funding. These are studies that are about to get off the ground recruiting. This is, just to let people know what's going on. It might be a nice little snapshot, but anyway, that's all.
Yeah, thank you.
Thanks for that, Serena.
And I should highlight also that, this has been sort of our kind of like our retrospective of like, what did we do with $3 million? And I actually think we did a lot. But even more than that, the PCPCRC has also continued to do other projects that, were not part of this specific funding envelope but that were still, are part of the PCPCRC. And so we've really grown in scope. And so like that mapping, that mental mapping that you're doing right now, I think I have also done, but with maybe a little bit less of a qualitative brain than Serena has. But okay. I do love color coding and I do love sticky notes. So but yeah, so it's actually like there's what we've presented, but there's actually so much more beyond that. And like I said, this was it's one slide per project. It's really doesn't do any of them justice individually, but again, when you put it together, I think there's a lot here. Yeah. See.
Thank you, Julie, for piloting that slide deck. I couldn't have done it, so props to you for getting it done within time. Having been a true beneficiary of this, the seed funding grants and how rewarding that's been for my program of research, maybe this is a hard question, but is that going to continue for our future junior researchers? Yeah, and what would that look like? Because it's been so successful. I hope it will.
Yeah, great question. And we would agree. I think there's been really phenomenal work that was done here. And I suspect that would only grow and continue if we're able to continue the program. So the answer is yes, we absolutely want to continue it. We have submitted a couple proposals for funding to have the seed funding program renewed, ideally to fund, I believe it's 4 seed funding projects per year for the next time frame. So we're still waiting back to hear on those. So, but we're hoping not to have to miss more than basically this 1 year, essentially, of the program. So we are actively pursuing avenues to do that. Yeah, of course. Great question.
Hello. Sorry, just to the newsletter point, that's such a great idea. I had done 4 issues and then I went on parental leave. Yeah, but we have a summer student who's helping out with stuff like that. We want to get it back going, but a problem was that not so many people were sharing things to. So anyways, when you hear from me or from Maya about submitting to the newsletter, please do share, because even if you feel as though, your circle knows what's going on and, you're like, everyone probably already knows about my paper being published or that kind of thing, the network is a lot bigger than we realize, and there are going to be, connections that can be made even just by sharing the same things over and over again. So please do share. And thank you for the suggestion.
Thanks, Fiona.
Like a monumental amount of work has been done, clearly. I just wanted to know, I don't know if you had any time to like reflect. I'm sure it wasn't all, a straight upward trajectory.
No.
Did you
No.
find like any commonality or solutions that worked over those 5 years? Was there more successful types of projects that you felt were able to get off the ground quickly, but also meet that impact that we're all looking for? I don't know if you had any time to reflect on some of that stuff.
Yeah, I reflect on that frequently. I don't know if reflect is the right word anymore. Maybe ruminate is more appropriate. But so I'm like both thankful but not for the question. But no, it's So in general, I think, there are certain types of studies that, well, I think different types of studies have different challenges. So, I spend the majority of my time doing more like clinical focused studies, like with direct interaction with patients and caregivers compared to like big data projects, for example. And so it's easy for me to sit here and be like, well, I have to get REB approvals and that takes forever. And then I got to get, intersite contract agreements in place and that takes forever. But then, there are also common experiences where trying to do a big data study where you share data across provinces and, can code things so that you can merge that data and analyze it together is also a challenge. And we saw both of those in the work that we did with Health Canada. I think what the commonality is that, and this is largely what the platform is trying to address, is that in any type of project that we've had here, there were, I would say, two really key challenges. The first, I said, related to like the administrative delays that come, whether it's on like the data contract side or, waiting for an analyst or an REB approval where you have to submit 5 different applications to 5 different ethics boards, right? So there's those. And I think the second big challenge is recruitment. And that's true of across like qualitative studies and for everything to trials. And so the platform, while it's, we're focusing on clinical trials, it really is designed to kind of target those two barriers that we see consistently across project types. Things like having master data sharing agreements across hubs and across provinces. Things like having one master protocol that's approved by an REB such that subsequent studies are just like amendments or sub-studies to that master protocol. So a faster process. And then having this sort of cohort of people who have already said, yeah, screen me for studies. Like I want to be involved in research. So we don't have to go and say, hi, Dr. Downer. My name's Julie. I'm a research staff. Can you ask your patient if your patient would be okay with me going and talking to them? And then, okay, well, what do you want me to talk to them about? Don't talk to them about anything specific. Just ask if I can talk to them about research, right? And I was, well, what's right? So like removing some of those barriers that we get to recruitment. And so I'm hopeful that the platform, again, that's some of the like the efficiencies that we'll gain from having this platform model. Yeah, I'm curious. There's a lot of people who are project PIs in the room, but I mean, for me, when I look at across studies, those were probably the two most substantial. Yeah. Does that answer your question? Yeah. Okay.
Just to jump in on that, because again, I know, and I hope that Health Canada, who funded this special programs, is cognizant of how much we were able to get out of this funding, like how many things were done for the pocket of funding that we received. And it was very generous funding. And, we feel very grateful for that. And we hope that we've repaid that investment with some real deliverables here that have made meaningful changes in human lives. But also, I think you haven't seen the effect of a lot of these projects yet. I think a lot of this stuff is early phase work that will pan out. And of course, early phase work is actually sometimes the hardest thing to get funded and the hardest thing to get going. The fact that so many people were able to jumpstart projects that will end up having more long downstream effects. I think it's hard to say. It's one of my favorite anecdotes. I think it was when Nixon first went to China, and sort of the rapprochement between America and China, and there was a Deng Xiaoping, who was the chairman, I think at the time, they were hosting a dinner for the Americans, and he was answering the question of what do you think the effect of the French Revolution was? And this was in 1973, and his answer was essentially, it's too early to tell. And I think that you haven't seen the effects of this yet, and that's what I think is really exciting. That said, as we put in a new proposal for more funding, we didn't want it to be just, let's just do the, run it back, right? Like we're not doing the same thing again, because I think we've, having seen this, we now see what is possible and what could be possible for a similar sized investment over 5 years. And how do we start to then continue to build on the team, the community, and the successes to really take it to the next level, so that we build an infrastructure that is stupendously efficient for churning out answers. Because again, when you're in academic world, you sometimes you can be forgiven for thinking that the measure of success in academia is grants and publications. It's not. It's results. It's changes in care. It's improvements in outcomes, which is unfortunately there's a lot of work that goes into that, and you have to do a lot of steps to connect that. This infrastructure hopefully can also be used for that, because it will be a great way to disseminate and then measure impacts of things down the road, not just research. And again, as we put in that new proposal, we want to keep the bench growing. We want to keep that seed funding, but we also want to make sure that we have that machine going that can make everything much easier, and make sure that every dollar gets spent, you get real yield for it. So
I mean,
I
a
did want
trials
to-
platform only works if you have phase 3 trials to
Yep,
do.
that's
And the
right.
only way you get there is work like this.
And that is from people like everyone who's in this room. So, Serena.
I think just in a similar vein, what I'm really struck by the 26 projects is the extent to which they are formative research, quasi-experimental research, observational research, mixed methods, and even implementation science. And, when this all got started, we were modeling ourselves off the critical care trials group. And, maybe we are aspiring still to a certain extent. And certainly with our CCS funding, there is an aspiration for trials work. But I hope we don't lose sight of the importance of the other types of research that is needed, not just as a stepping stone for a phase 3 trial or whatever, but also just for value in and of itself. And, I know with the work William and I have been doing around home visits using ICS and other health administrative data, sometimes we get feedback from reviewers that's like, what's the point of observational research? You can't determine causation. You need to do a trial. And the reality is, in certain circumstances, you need population level research. So I think that keeping the diversity of methods alive in what we're doing is really important, and something that I think makes us unique.
Yeah, I would totally agree. And I've 2 follow-ups to that. One is that there's value in that work, to your point, in and of itself. And I think perhaps one of the biggest value adds of that work is that it doesn't lose sight of the patient voice and the caregiver voice, and of the healthcare provider voice, because at the end of the day, those are the groups of people that we're here to serve, that we're here to help. That if we're doing our jobs right, that we are helping. And so I think a lot of times those methods are really the best way to get at that, and to make sure that what we're doing matters to the people who we're trying to help. The other sort of takeaway that I have from your comment, Serena, is around, we really try to preach this idea of programs of research. And in a program of research, you're trying to solve a problem. You're not trying to do a qualitative study. You're not trying to do a trial. You're not trying to, right? You're trying to solve a problem. And most problems worth solving aren't going to be solved by one trial or one observational study or one qualitative study. And so I think I'll use Homer as an example, right? That project started with, some observational work, and then some pilot work, and then some qualitative work looking at acceptability to patients. Then we had this big hybrid implementation effectiveness trial, then a linkage to ICES to, look at longitudinal outcomes. And now I'm at a spot where I'm talking to Z and I'm like, I think we might actually have to go back to do some more qualitative work to dig into why healthcare providers aren't responding to the screens for racialized and newcomer individuals. And so it's this constant cycle of there's this bigger problem that we're trying to solve. And I think if you become just a group that does trials or just a group that does something, you start trying to get papers rather than solve problems. And I feel really good about the fact that we're a group that wants to solve problems, and for people. Yeah.
I am not seeing any other comments. I don't know if we have any online, but listen, Julie, thank you very much for taking us through all of that.
Thank you.
And of course, big thanks to Julie for being really the My favorite metaphor, the glue that holds together the gears, this as well. But of course, Maya and Fiona, as you
I'll come up with a
Fiona's
better
work-
one.
Yeah. No. That was straight stolen from The Simpsons. But of course, Maya, thank you so much for all your help in organizing, coordinating all of this. Fiona, for the awesome graphics that make it all make sense. And thank you to everybody who was part of one of these projects, who supported one of these projects. And even if your name doesn't appear, you made some clever comments in a session and feedback, because I know particularly the seed projects, all the projects, but particularly the seed projects, heavily benefited from the sort of probing process of getting feedback and the evaluations that went through. So thank you